Yes. And just to confirm, Dr. Shruti, it might be uploaded to the YouTube and you should not be having any problem with that. Is that okay?
Yes.
Okay, perfect. Okay, so everyone, whoever has joined now, so we have taken this reduced fetal moments with the growth concerns, and this is from the May 2026, and you have got total 5 slides to go through. Yes, your 2 minute begins now.
Okay, can second slide now? Ma'am, second slide.
This is your second slide.
I cannot see.
You cannot see?
Ma'am, I'll just rejoin. I think my net is there's a problem. I'll just join back.
Okay, no problem.
Actually, slide.
Okay, this is your first slide.
Yes, ma'am. Second slide.
Can I show the other part of it?
Yes, ma'am. Okay, next slide, ma'am. Okay, next slide, ma'am.
I move to the next.
Okay, next slide. Okay, next slide, ma'am. Okay, next slide, ma'am.
That's it, yeah. Okay, happy to start?
Yes, ma'am.
Please start.
Hello, I'm Dr. Shruti, one of the doctors in here. May I confirm your name and age, please?
Hello, doctor. I'm Sarah Michelle. I'm 38.
And how would you like me to address you?
Sarah is okay.
Okay, Sarah. First of all, I would really like to apologize that the current consultant is currently unavailable, and she has asked me to see you. Is it okay if I continue consultation? I am the ST5 here.
Yeah, that's fine, doctor.
Okay. Sarah, I can see that this is your first pregnancy. You are 32 weeks, and you're having some reduced fetal movements. Isn't that correct?
Oh, yes, doctor, that's correct. I have been experiencing this reduction in my baby moment since yesterday. And then I
Mm-hmm.
went to my midwife, and then she said that I need to get the scan done. I have done the scans and other things. So I'm really
Mm-hmm.
worried, doctor. Is everything okay with my baby?
Mm-hmm. Yes, I have your reports here with me. I can discuss them, or maybe I can ask you a few questions to know you first better, and then I can explain to them in a better.
Ask me, doctor. That's fine. You can ask.
All right. I would like to ask you a few questions, and then we'll be discussing your concerns, and we'll explain the management options. Can you tell me more about your concerns and expectations from today's meeting?
Oh, nothing. I just want to understand, whether my baby is okay, whether I need an immediate delivery or something, because the midwife was saying that there could be some problem with the growth of the baby. So that's
Mm-hmm.
why I'm really worried, doctor, because I'm only 32 weeks now.
Mm-hmm. I understand. And uh, when did you feel these reduced fetal movements?
Since yesterday night.
And is it still there? Have you felt any movements from then?
Movements are there, but I'm not happy about it.
Okay, would you like me to take a quick, I can check the baby's heartbeat if
Doctor,
that's
that
okay.
has been done. I think it must have been provided to you. Just now they've checked that.
All right. And can you tell me, was this the first episode or were there previous episodes as well?
No, this is the first time I'm experiencing this.
Okay. And mm, can you tell me if there was any leaking of any fluids from down below?
Nothing at
Any,
all.
any pain in your tummy?
No,
Okay. And may I know if you're seeing a GP for any medical conditions,
no, nothing.
any allergies that you're aware of,
No,
any surgeries you've had in the past,
no, 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 nothing.
any history of increased blood pressures or diabetes,
No,
any family history of concerns,
nothing, doctor.
any clots in you or your family?
No.
Okay. And don't mind me asking, but do you smoke, Sarah?
I mean, I used to smoke before this pregnancy, but once I got to know
Mhm.
that I'm pregnant, I have quit it.
I really appreciate that, Sarah. That was a good decision. And don't mind me asking, do you drink alcohol?
No, no,
Okay. And pardon me for asking, any use of drugs?
no.
Okay. And may I know, are you aware of your weight to height ratio?
It's normal, doctor.
Okay. And are you aware of your blood group?
I think it's B positive or something.
Any reservations for transfusion?
No.
Okay. And is it okay, Sarah, if I quickly examine you in the presence of a chaperone, just to have a look at your baby
Yeah,
and
that's
your
fine.
observations? Yeah. Okay. Thank you, Sarah. Is there anything else you would like to add?
Nothing, doctor. I mean, as far as my pregnancy is concerned, they have done some, initially they told that there could be some problem because I underwent some anomaly scan, and before that, even my one of the blood markers, they said that my baby could be at a high risk of growth problems, and I have been following up regularly. Initially, they said that I need a serial growth scans,
Mm-hmm.
and so initially the midwife was monitoring me with all those tummy measurements, and then from 28 weeks onwards, they told me to, get these scans done. So I have been following up with
Mm-hmm.
regularly with these scans. So now I really want to understand what's going on.
Yes, Sarah. And are you aware at all about your scan reports?
Nothing like she told that it could be some growth problem. I'm not quite sure.
Mm-hmm. Okay. Sarah, would you like to call in somebody before I explain the reports to you?
No, that's fine, doctor. You can tell me.
Okay, so I've seen the name and the NHS number, and I've confirmed the report belongs to you. There are some blood reports and the baby's the scan reports. In the blood reports, everything seems to be normal. The fluid in the back of the baby's neck also seems to be normal. Coming to your scans, which were basically done to see the blood supply to the baby, this was done. Your Previously it was done, which had some concerns, and that's why you were offered some serial scans. Now, the seek the growth of the baby. We can see that the baby's growth is not. the baby is not growing as it was intended to grow, and the baby has a static growth, which means that the baby's growth has stopped and is remaining the same. Are you getting me?
Okay, all right. But is it is
Mhm.
it is it something serious? Is my baby okay?
So the growth, yes, it is between the 10th and the 90th centile, which means that it is a little small, but it is still okay. But coming to the blood supply, which is going to the baby, so we check the Dopplers. These are known as the umbilical artery Doppler. In this, there is a little concern, which is showing that there is a resistance to the flow to the baby. So this means the baby may not be receiving enough. The baby may not be receiving enough blood flow, and if it is not corrected and not closely monitored, this can become a problem in the future. Are you getting
Oh,
me?
oh, okay. Then what options I do have, doctor? How do I make sure that everything is okay?
Yes, Sarah, that is a very valid question. And I would like to tell you that the reassuring part is that the ductus venosus, which we have done, that is the blood flow to the heart, and that looks normal for now, and that we will be monitoring that. And also your the electronic CTG, which is the electronic trace of heart, that was done, in which the value is around 3.2, which is also a little bit of concern because it is less than what we normally expect. So coming to your management, it will be now it will be treated as a high risk
What do
pregnancy,
you
and
mean
you'll
by
be
that? Do I need a cesarean section? Do I need to deliver immediately? Are you going to deliver my baby now?
I'm sorry, Sarah, you mistook me. It is we'll be just admitting you right now, and we'll be closely monitoring you, and we'll also be doing your the electronic CTG to look for these variations, and this will be and along with the ductus venosus Doppler, this will be done at a weekly basis, and at a yeah, and so for this we need to admit you, and you will be looked after by my consultant, the baby doctor, the fetal medicine unit, the specialist nurse, the imaging doctors, and we are here to support you. Any questions so far?
No, no question so far, doctor. Then when am I supposed to deliver then? How
So
how will be my follow-up?
Mm-hmm. So right now you are 32 weeks. So we are going to closely monitor you. This will be done weekly. We will plan because your these electronic heartbeat it shows 3.2. We usually deliver babies by the age of 34 weeks. So we will plan. We will already start you. So we'll give you some injections like steroids for the maturity of your baby's lungs, so that when the baby does deliver, the baby does not have problems with breathing. We will also ask the baby doctor to see you and discuss. And if you would like, I know because you're alone, you can call your partner and we can discuss this together. And I know it's a lot of information. I'll be giving you patient information leaflets. And if at any time you have any doubts, you can call us. If you have any bleeding or tummy pain or reduced fetal movements, please let us know. Uh, uh,
Doctor, you have done all the tests. What is the need for me to get admitted now?
so as I said, Sarah, this requires close monitoring, and we do not want it to become worse, and we do not want any the flow, the Doppler, the blood flows to reduce to the baby. Are you getting me?
Okay, so you will be repeating the scan?
Uh, because this was already. May I know when was the scan done exactly?
Everything was done today. The growth scan and all
Yes.
that with the
So we will
doctor.
repeat the scan and the Dopplers in 1 week, but we will keep you an electronic CTG that will be done on a daily basis, and that will be done. Yeah.
Mm-hmm.
So
Okay.
that for that we need to admit you.
Okay. So if everything is normal, I can get discharged and can I come after a week?
Mm,
Okay.
so Sarah,
All
I
right.
will be talking to my consultant, and then we can make a decision, and then I will come back to you.
Okay, your time is up. All right. Well done for attempting. Yes, over to you, Dr. Shruti.
A little bit, I was confused with the. I couldn't. There were so many charts, ma'am. I
If
don't know
you
if
had
there is.
asked me, if you had asked me how was my pregnancy, I would have given you so much of information.
Oh, oh,
And
oh, oh, oh.
you totally forgot on the pregnancy so far, the
Yes,
course
some
so far. Why was she under serial growth monitoring? Isn't it?
definitely.
Yeah, that's all right. That's why I myself had to prompt you that this is going on with me for a while now. Okay,
Mm-hmm.
so how many of you, except the people who are in the paid batch course, how many of you agree the management Dr. Shruti has quoted to this particular patient?
Ma'am, the patient is 32 weeks, and at that time, the short-term variation is less than 3.5.
Zubia,
There needs to be delivered.
Zubia, not you. That's why I told you, not
Uh,
you. Yeah, I know you know the answer. Yeah, others?
Yeah, ma'am, the variability should be more than, it should be 3.5 between 30 to 34. It is less than that. So we
Mm-hmm.
have to plan delivery after
And
giving
how do you,
steroid coverage. Yeah. Steroid and MGSO4. Yeah.
again, how do you deliver her?
Because still the diastolic flow is there in the umbilical artery, we can
How
go
do you
for
deliver
trial.
her? Mode of delivery.
Yeah, we will go for a trial of normal delivery. But
But
yeah,
Shruti, with
high
Dr.
sustain.
Shruti saying ductus venosus is still present.
No, once the umbilical artery PI is high, we monitor them by bi-weekly CCTs and ductus venosus Doppler. And if the CCTG is less than 3.5 between 32 and 34 weeks, then we plan delivery. And if
Okay,
the
fair enough.
diastolic flow is present, then we can go for a normal delivery by inducing her. Of course, a high chance of getting taking her up for cesarean section if something goes wrong. Yeah.
Okay.
And we
Yeah.
have time to give steroid also.
Okay. Yeah. You're almost partly there. Okay. So before we come to the discussion in detail, I'll clarify everything because there are a lot of confusions in
Hi,
that
doctor.
the FGR.
Sorry to interrupt. Sorry
Yes.
to interrupt. Dr. Deepika, I would like to go for a cesarean section because this is a preterm breech with Doppler abnormalities.
Mhm.
So
What
rather
if it
than
was a
infuse,
cephalic?
uh, but still, if there is a Doppler abnormality, I would like to go for a C-section.
Doctor abnormality is a Doppler abnormality is a wide range to be specific.
Uh,
What what Doppler abnormality is making you think that we should go for cesarean section?
Absent or
right now,
regressive
right
Okay.
now the ductus venosus
short-term
Doppler is normal.
variability.
Yeah, right now the ductus venosus Doppler is normal, but the short-term variability is less than 3.5. So that is a
Mm-hmm.
little concerning. So this
Mm-hmm.
I
Little
feel that
More
concerning,
we
no, it's a
concern.
big red flag. Okay, that's a big red
okay,
flag. You have to
okay,
have any of the one following to go and deliver her. We are not looking at every parameter. Okay, we'll come to
okay,
that. Yes, you were
okay.
almost, everybody is almost getting it right. So the 2024 fetal growth restriction has become a bit difficult for people to understand. We ourselves as mentors took some time to decode it. So I will share all of that with you. We'll have a good Q&A questions, and I will promise you that end of the day you will definitely understand most of the stuff out of here. So please stay with me till the end of the discussion. I'll bet you that no one will make it this easy for you guys. So yes. So as far as this, the overall, the feedback is concerned, Dr. Shruti, you were extremely good. You are a good candidate. You are on the right track. Your speed is good, and your information gathering was also like focused. You did not go here and there tangentially. Okay. And the I was what I was very happy about your presentation was that you were not making a bigger sentences in your focused history taking. I mean to say, few people always try to club the open-ended questions and an open-ended question with a close-ended questions. They keep rephrasing that. Do you have any medical conditions like diabetes, hypertension that you see your GP for? Utter nonsense. You don't have so much of time for all of that. Okay, keep it simple. Any medical conditions, any allergies, any surgeries in the past, you have to ask similarly so that you will be able to finish your information gathering in less than 3 minutes of time. The intro and rapport building, you should never exceed more than a minute. This you have to take care of when you are practicing with yourself or with somebody else. At least your study buddy should be able to say that you took more than a minute for your intro and rapport building and making an agenda, and you took more than 4 minutes, 5 minutes in your information gathering. That is the sort of the practice you guys need with your study buddy. So I was happy that you were very crystal clear in your information gathering. You were not taking a longer sentences there. Okay. So your introduction and greeting was good. Okay, you quickly confirmed her name, age, and introduced yourself, the preferred way of addressing her, and you apologized for consultants' unavailability. Very, very, very important. Remember that this is not a fancy thing. This is not at all a fancy thing that you are going to apologize for consultants' unavailability. This is one of the borderline point under, this is a mark under communication with the colleagues. If you miss this, and that is one borderline point, and if you miss not mentioning all the people on the MDT, okay, that's one more borderline point. So getting two borderline points will get you fail in that particular domain. I'm not talking like you're going to flunk the entire station. This is the domain wise marking at the end of the day. You may pass few domains, you may fail few domains, you may get borderline in few domains. So apologizing for consultants' unavailability is a mark under communication with the colleagues. Wherever you see explicitly they mention that your consultant is busy, they asked you to see the patient, or if they have said there is a GP letter, the midwife has written a letter to the consultant, that is also where you have to apologize for consultants' unavailability, which was good that she took care of that as well. And then, so you told her that you would immediately escalate the care to the consultant, which was good. And you asked her ideas, concerns, expectation, that what worries her the most now. Very, very important. And reassured her that you will formulate a safe management plan with her. Don't worry, you're in safe hands. We involve the consultant, the right team, and take all the necessary steps to keep you and your baby safe. So have that empathy part in there and then move forward. So another thing she was very good at is that she understood that the patient is very anxious. So she gave an option whether she wants to discuss the reports right away or she's happy to answer a few questions for her. She gave both the options. Again, a very good approach, Dr. Shruti. So as far as the information gathering is concerned, started with the presenting complaint, which was good, which is reduction in the fetal movement. So since when she has started noticing this reduction in the movements? Is it the first episode, second episode, associated with any, the red flags like contraction, bleeding, leaking, feeling unwell in general, all those you covered. And then you covered the medical conditions, you covered addictions, covered BMI, blood group, reservation. Blood group and reservation also are important here because we are taking her up for cesarean section. And then only thing which you missed was the entire pregnancy journey. Yes, Dr. Shruti?
Yes, I don't know
So
why.
that gets you, yeah, that gets you borderline in the information gathering. It's not like you didn't know. Maybe you were overwhelmed with the type of task you got, so that's why it got out of your rhythm. So what exactly you need to ask is that ask an open questions. Can you tell me more about your current pregnancy, please? So she will tell you that it's a normal pregnancy, doctor. This is my second pregnancy. Previously, I had a normal vaginal delivery, blah, blah, blah. Then you have to specifically ask. The reason why I'm asking is that she is 32 weeks now, but you have been provided with her all the antenatal, from the booking visit. You can see here. This particular one is saying about the first trimester aneuploidy screening, and it says the papier is low. Even if you don't look at this, see the interpretation here that papier is low. Fetal growth surveillance is recommended. This was enough for you to quickly, understand what's going on here. And then if you look at it, this one is around, anomaly scan, and they have given uterine artery Doppler is increased in resistance, and there is a diastolic notch in here. Okay. So even if you don't understand the graph, I'll tell you it's very easy. So that the peak has been increased. Okay, this is the systole. This part, the peak is systole, and this trough part is basically diastole. So this has been increased so that the PI of the uterine artery is increased, and the end diastolic, if you look at the diastole, there is an end diastolic notch. This is the notch. This is the notch. This is the notch you're talking about. So if they have not given the interpretation, then you have to interpret. Otherwise, you have to understand from the comments. So from the comments, they have given there that the pulsatility index of the the uterine artery Doppler is increased, and there is an end diastolic flow, end diastolic notches there. So again, they have correlated it with increased risk of preeclampsia, fetal growth restriction. So she would require a serial growth scan. So this much you understood. This is not her recent scans or recent blood tests. Okay. So you have to ask her. Looking at that, you need to ask her that what exactly was told to you, what happened during your pregnancy, was anything told about the growth concerns, because I can see from your the blood test and the initial 5th month scan that there were some Doppler changes. Can you tell me more about that if she doesn't say? Otherwise she will be instructed to tell to you once you ask about the pregnancy details. It will not be that complicated. It will not be made that complicated to ask a leading question. So yes, she had a low papa. She had a uterine artery Doppler. Low papa itself is a high risk factor. Okay, I will come to the chart and show you guys. So you have a low risk, you have got the, the moderate risk factors, and then you have got high risk factors. So your low papa is a high risk factor. Okay, all those high risk factor women will be subjected to the uterine artery Doppler at 5th month scan. Okay, along with their anomaly scan. So in that 5th month scan, they look at what is the uterine artery Doppler, and based on that, they will recommend the serial growth scans. It could be from 28 weeks onwards or 32 weeks onwards. It depends depending upon uterine artery is abnormal or not. Okay, I will come to that later. So you should have asked all of that. And also whoever is a high risk women, and they will be usually put on the aspirin as well. You need to ask that whether she is put on the aspirin or not. So now you understood her pregnancy details, that it's an anomaly scan. There were some uterine artery Doppler changes as well, and low papa and aspirin. But these people usually will be monitored when the uterine artery is abnormal. Okay, when the uterine artery is abnormal, they generally be monitored from certain 28 or 32 weeks onwards. Before that, where she will be under? She will be under midwife. Okay, midwife only will be monitoring her with the regular appointments. She will be checking the symphysiofundal heights and measuring it. Okay, that is why you get to see these growth charts. The people who are not working in the UK may find it a bit difficult. So let me just explain how it is being done. So these are the Grow 2.0 charts. So basically these are the softwares. Okay, Grow 2.0 charts are basically the software. So in that, usually the midwife measures the symphysiofundal height, and she will upload it on the software. There is an app. Okay, app for the midwives, app for the doctors, app for the patients are also there. Patient also can check that how my baby is growing. So in this, the first growth scan, if you see there, this is a normal one. This is just, they have given the normal. In the exam also, they had given the normal growth charts also. People got confused that it is normal. Okay, look at what they are measuring in here. Are they measuring the fundal height? Are they measuring the fetal weight? These are the two things that you have to look at it. Another, even if you forget to look at this, another way of identifying whether you are monitoring a fundal height or fundal weight is it into, or is it an X or a cross, or is it like round, like a circle? If it is into, then they're generally measuring the symphysiofundal height. Okay, if it is a round, like the circle, I'll show you here. Yeah, like this, the other one, that means they are measuring the fetal weight. So the first one is a normal one, that is 40 weeks. They have just given you an example that how it works. 40 weeker. She's not 40 weeker. She's 32 weeker. So this is a normal one. So here they have plotted the symphysiofundal height, symphysiofundal height, symphysiofundal height, symphysiofundal height up to 40 weeks, because she never came to the serial growth scans biometry because she is a normal low risk lady. So this is a normal scan. So the top one is the 97th centile, and this one is the 90th centile. The middle one you can see here is the 50th. This is the 10th centile, and this is the 3rd centile. Concentrate on these two, the 10th and 3rd centile, whether your marking is coming below that or not. That's important. So everything is above 50th centile and below 90th centile here. Okay, please everybody mute your camera and the mic, please. Yes, perfect. Okay, clear up till now? How to interpret this? Yes? Be with me, guys. We need to discuss a lot of things. Yes. So now look at this. This is from the midwife. This is from the midwife because before 32 weeks, she was with the midwife because her serial growth scan started from 32 weeks onwards. So here you can see here, this one is actually saying that she's on the 90th centile. Then it was still growing good. Okay. Even after the 28 weeks, it's still growing good. And then suddenly you can see here that it has, it has been slow. Okay, it was almost like dropped to the 50th centile. So anyway, she was under fetal growth monitoring from the 32 weeks. So immediately the midwife has referred for the serial growth scans. So from the serial growth scans, you can see here, this is a fetal weight we are talking about because she started with the monitoring here. So again, it is falling, and eventually when you look at 32 weeks, So it was almost touching the 10th centile. It is almost like 16.4 centile. Not necessarily less than 10th centile, but it is still, there is a reduction in the growth in here. Okay, this is what you should remember, that it is touching almost the 10th centile. So this much you understood. But anyways, even if you have not decoded this growth charts at all, even people who have not decoded the charts at all in that 2 minutes reading time, people who were smart, they still decoded the station and told that she would require a cesarean section just based on one finding. What is it?
Breach.
Breach.
No.
Short-term variability.
Short-term variation. STV was enough for you guys to go and deliver her, because we give so much of importance to that. I'll come to it. Okay, so then looking at the umbilical artery Doppler, the end diastolic flow is still present. Okay, it is more than 95th centile. There was no indication to do the ductus venosus. She was already 32 weeks. Anyways, she was under follow-up by the fetal medicine specialist already. So they have done it. That is not something which is going to decide my delivery now, not the ductus venosus. Okay. Short-term variations on your computerized CTG. I'll just give you 2 lines on the the computerized CTG for the people who are in Asia and other regions who are not practicing in the UK. What we follow in the NHS is physiological interpretation of CTG. Okay, we don't follow nice guidelines. We don't say pathological CTG, suspicious CTG, normal CTG, reactive, non-reactive. All those words are not being used in the NHS. We follow computerized CTG for antenatal CTG. Okay, we follow something called as acute hypoxia, subacute hypoxia, chronic hypoxia, gradually evolving hypoxia. Okay, so these are the things that we communicate. So in the computerized CTG, which is basically, we have taken hundreds and lakhs of these NSTs, okay, the CTG traces. We have given it to the software, and the software has identified those variations, the beat to beat variations, the human naked eyes cannot detect otherwise. Okay, otherwise, because something which is this B2B variability may be normal for me, for others it may be normal, because 5 to 25, all this is not there with us. That nice guidelines of 5 to 25 is not there with us. We look at the short-term variation, long-term variations. Okay, we look at high episodes, low episodes, angular acceleration. There's so many, there's 12 to 13 points are there on the computerized CTG. We expect every parameter to meet the criteria, and then we will get that computerized CTG is normal because it has met that Dawson-Redman criteria. Do you have to break your head about it? You have to go and read about it? No. All you have to remember is that computerized CTG is something like an antenatal CTG for women. To identify the chronic hypoxia, we decide whether the baby is fit for going into labor or not. We don't subject the baby to go into labor, stress it more, and then take her up for the cesarean section. No. Before going into the labor, before the stress begins itself, we decide whether the baby is fit for going into the labor or not. That is what we do from the computerized CTG to look for the chronic hypoxia. Don't worry about those 12, 13 parameters. Remember only the short-term variation and gestational specific short-term variation. That is all we are more interested in, because these are fluctuations are not visibly seen in the naked eye. This needs a computerized interpretation. The moment you see the short-term variation is less, that's it. Irrespective of your ductus venosus, irrespective of your umbilical artery Doppler, whether end diastolic present, not present, do not bother. Deliver her. Deliver her. Is it category 1? No, it is not category 1. Is it category 2? Not really. Category 3. Okay? Category 3. So prepare her, admit her, give her the magnesium sulfate, depending upon the gestational age, give her the steroids, prep her up, involve everybody, take her up for the cesarean section. Until then, you continuously monitor on her computerized CTG. Clear? Any question about the computerized CTG? Don't apply your non-stress test results or your nice guidelines in here. That is no longer we follow.
Madam,
Anyone?
if it had been a cephalic presentation, then the variability is indication for cesarean section as well. We will not go for trial of labor. This is a breach, therefore it's a cesarean section indication that I missed definitely. But if it had been a cephalic presentation and the variability is low, but the DV Doppler has got diastolic flow present, even then we would have been gone for cesarean section directly?
Yeah, I'll come to that because there is there is some confusion in this particular topic. 32 weeks and above is somebody, we call it as, she was not diagnosed with any, the growth problems before. She was only under serial growth monitoring. This is when, 32 weeks only, when we understood that there is this FGR that has set in. She has come with a reduced fetal movements as well. And irrespective of your ductus venosus, we are going to deliver her, because even if you take the ductus venosus and the short-term variation, any one of the following should be there to go and deliver her. Either the ductus venosus, if it is abnormal, you deliver. Even if it is normal, short-term variation is enough for us to go and deliver her. It is nothing related to your breech or cephalic. Forget about the breech from your head now. Okay, dear Yamini? I will show you the charts. You will understand better.
Ma'am,
Yeah.
also, is short-term variation done in raised pulsatility index? Is it
Okay,
only?
I will answer everything. I will answer everything. Just remember whatever I'm telling you guys now. I will answer everything to you guys so that it will be easier. Okay, so next would be, so what are we gonna do now? So you have to explain her. Okay, you have to explain her that what exactly we are dealing with the condition in here. Examination she offered, and then interpretation she checked and offered a support in the form of a midwife and a partner, confirmed the identity on the name, age, NHS number. She also told that she has reviewed all the growth charts and computerized CTG. So explain the reason for surveillance, because she had a low papa, she had an abnormal anomaly scan. So that's why we were monitoring initially with the symphysiofundal heights, that is tummy measurements. And since the baby weight was falling, so we took the serial growth scans and Dopplers today, and also she had a concern about baby movements. And beautifully, Shruti mentioned that the baby growth is smaller than expected. That is the reason we checked this Doppler, the special scan, to look at the blood flow to the baby, and the blood flow is preserved. Okay, even though there is a resistance, there is a less blood which is reaching the baby. Okay. However, there is this one particular test, what we call the computerized CTG. Okay, that will tell us how the baby is doing at currently, which is less than the usual for that particular this thing. Computerized CTG is always done for 60 minutes to call it as whether it is meeting the criteria, not meeting the criteria. It is not 20 minutes, 30 minutes. If it has met in 10 minutes, 5 minutes, we'll just cut it off. If it has not met, then we keep doing it for 60 minutes until it has to meet the criteria. So we generally take it for 60 minutes, and even if it has not met the criteria, short-term variation is less than 3.2, which is less than 3.5 milliseconds between 32 to 33 plus 6. Between 32 to 33 plus 6, it is less than 3.5. It is abnormal. You have to tell her that baby is compromised. Baby is not happy inside. Baby is not coping well. Okay. At the moment, blood flow is still reserved, but this particular short-term variation is telling that baby is not happy inside, not coping well. Continuing the pregnancy is unsafe. If she says, doctor, I'm only 32 weeks, then how am I gonna, it's too early for me. How am I gonna, survive with all of this? So tell her that why are we suggesting an emergency delivery for her? It's very, very important you tell her that the short-term variation is less than 3.2, which is below 3.5, which is for that particular, the pregnancy age. This will tell us that baby is no longer coping inside the womb. All the blood flow is still present. Continuing the pregnancy is likely riskier, and we need to deliver the baby urgently by cesarean section, because we can lose the baby at any point of time. It can worsen, we can lose the baby anytime, and when that happens is quite unpredictable. I'm really sorry to be giving you this information, but this is what it is. Okay, it's very, very important. The lay examiner will be watching you. It's important that you balance the information with the reassurance. Baby is no longer coping well inside the womb. It can deteriorate suddenly. We cannot predict when that happen. We could even lose the baby. So definitely delivering your baby is safer than continuing the baby. But we'll take all the measures. We give the steroid injections, we give the magnesium sulfate injection, we'll involve the neonatal team. They will be present at the time of delivery, and we will go and deliver the baby with a cesarean section. Once the baby is being delivered, we will admit the baby in neonatal unit because the baby is small. We don't expect the lungs to be fully mature. Baby can struggle with breathing, feeding difficulties. That is the reason we monitor closely. Okay, this is all you will tell her. But once you tell her the baby can die inside the womb, she will naturally accept your plan of management. I will answer all your questions. These are the common questions that will come to you. But let me just finish this task so that we can take the questions. Okay, I'm not dismissing your concerns. So the GROW 2.0 is basically it's an electronic version of the gestation related optimal weight chart. So as I mentioned that we can use it for both. Okay, we can use it for even the fundal height. We can use it for the fundal weight, fundal height and fetal weight. So both can be used. Okay, here they have taken fetal weight. That is why you can see it in the form of circle here, and they have been monitoring. Okay, it's very, very easy. So you can just look at how many weeks. Okay, and the growth is low here because it has fallen. Okay, and so she will be being monitored under serial growth scans. So this is what is the GROW 2.0 charts that you guys should be familiar with the lines and everything. Okay, it is available in the mobile app as well. So this is very much customized. They use the ethnic origin, height and weight, the pre-pregnancy weight, and even for the twin pregnancies, you can get to see the twin discordance as well. So it's very much some, it's easily used by the midwives in here. And even the patients also can log in through their own user ID and password. They can also see how the baby is growing. It will be shown in a simple diagrams over there. Okay, so this is again a normal GROW 2.0 charts that you should remember. This is 40 weeks. Okay, everything is normal. Okay, and this is only the fundal weight they are measuring. This is between the 50th percentile and 90th percentile. It is going properly. The growth trajectory seems to be fine in here. Okay, and this is one of another GROW 2.0 chart which I'm going to show here. Again, here also they are measuring the fundal height. Okay, I think it's missing. It has to be into. Okay, because this I have created on my own. So that's why some mistakes are there. Okay, this is into. Okay, and she's 36 weeks and growth is falling because it is almost touching the 10th percentile. So it is 60th percentile in here. Okay, so this is one more GROW 2.0 chart which I'm going to show in here is 37 weeks. Again, they have monitored the fundal height and it is falling in here. Okay, so you can go through it. Not only your not only the FGR, even the macrosomia also can be diagnosed with this, where it is more than 90th percentile persistently, more than 95th percentile persistently. Even the macrosomia babies also can be plotted in here. So now I will take the first question here. So she has got high risk factors, I told. If she is a low risk, no risk factors, okay, then we will only do the serial measurements of symphysia fundal height that the midwife will be doing. If it is less than 10th percentile, then they will be subjected to the biometry and the umbilical artery Doppler. So high risk factors, this is where maximum questions are coming. You guys have to pay attention here. One is that medical history. If she had any maternal medical conditions like chronic kidney disease, APLA, autoimmune conditions, that is where she comes under high risk, where you deal with this maternal medicine module, right? All those maternal medicine topics would require your serial growth scans because they're all high risk factors. Second is the obstetric history, especially the previous obstetric history. If any baby was diagnosed with previous history of FGR or a stillborn, or previously she had a hypertension in the previous pregnancy. Okay, all those also will come under eligible for the high risk factors and serial growth monitoring. Then they are asking these things. Papa less than fifth percentile itself is making her high risk factor. Echogenic bowel, presence of echogenic bowel, you get to see that in your antenatal care. Presence of echogenic bowel where you have to, that's a patient safety point that you have to advise her the serial growth scans. Okay, very, very, very important. Then any significant bleeding, and then single umbilical artery. These are the common things that they're testing you. Okay, Papa, echogenic bowel, and single umbilical artery. All these people, you should start aspirin for them, 150 milligrams, okay, less than 16 weeks. Then subject them to the uterine artery Doppler during anomaly scan. So how you should remember is that in that we are checking two things. One is the uterine artery Doppler, because to recommend serial growth scans from what gestational age, I will make it simple for you guys. One, you have to look at the uterine artery Doppler and estimated fetal weight. If both are normal, that is, she's a high risk lady for sure, she requires a serial growth scans for sure, but her uterine artery Doppler is normal and estimated fetal weight is also more than or equal to 10th centile. That means both the parameters are normal. Then from 32 weeks onwards, okay, from 32 weeks onwards, if any one is abnormal, be it uterine artery Doppler or estimated fetal weight is less than 10th centile, then you do it from 28 weeks. Forget about this 26. Okay, this is, I'm just trying to make you guys simplified because you're not giving part 2 to be very, very specific. Okay, so remember, if normal uterine artery Doppler and your estimated fetal weight is less than 10th centile, or your abnormal uterine artery Doppler but normal estimated fetal weight. How to remember it? Any one, either one is abnormal, then from 28 weeks onwards. Third thing, abnormal uterine Doppler is also there. Along with that, estimated fetal weight is also less than 10th centile. That means both are abnormal. Refer them to the fetal medicine specialist, because it's important to rule out some chromosomal abnormalities, any structural problems in the baby, or any, the torch infections in the baby that could be associated. Involve the fetal medicine specialist there. Okay, so three things that I want you guys to repeat before we move on to the next one. Any one of you? Quick.
So we look at two things, one uterine artery Doppler and one the expected fetal weight. So if both are normal, then we'll do serial scanning from 32 weeks. If either of them is abnormal, then we'll do serial scanning from 28 weeks.
Yes.
And if both are abnormal, we're going to refer them to the fetal medicine.
Perfect. Okay, understood everybody? All of you reply.
Yes, ma'am.
Yes.
Okay, perfect. So let's look at this particular one now. Here is where there is a contradictory statement from the guideline. If you read the guideline, nowhere it mentions from 32 weeks onwards, 32 and above, you should be doing the ductus venosus. If you read the recommendations, if you read the guideline in detail, it nowhere says that you need to do the ductus venosus from 32 weeks onwards. However, if you look at this picture, it says that between 32 to 33 plus 6, you can still do the ductus venosus. Okay, this is the confusion number one. Irrespective of it, irrespective of this, gray zone, any one is abnormal is enough for us to go and deliver the baby. Remember this, or. We are giving so much of importance to your short-term variations there. Anytime on the computerized CTG, you see repeated unprovoked decelerations are there on the computerized CTG, enough for you to go and deliver the baby irrespective of the gestational age. Maternal indication like uncontrolled hypertension, significant proteinuria, she's almost in impending eclampsia and things like that. Yes, you're delivering her immediately. You're not looking at any of these. Okay, that becomes like a category 1 cesarean section for us for the maternal and fetal indication. If that is not there, then we look at these parameters. Depending upon the gestational age, ductus venosus, short-term variations, we look at it. But any one abnormality is enough for us to go and deliver the baby. Did I clarify the doubt here?
But he didn't specify that we should go for cesarean section if the short-term variation is low.
Yeah, I will come to that,
Same
dear.
way,
I'll explain that.
make it absent and reversed. He make it clear. Sorry for
Are you
that.
no. Are you trying to say that? Is it something I'm saying? Is it wrong?
No, no,
Is it?
no, no, not sure. No, no, no. But I
Uh-huh.
am saying, like, he didn't clarify in the graph. Same that way he done an absent and reverse it, that we should go
So
for
for that, you
cesarean
need to read
section.
the entire guideline. I have
Yes,
decoded it
yes,
for
that's
you. I will
why.
I
That's
will
why.
explain. So I'm trying to understand that am I going anywhere
You are
the wrong
very good.
direction?
Thank you. No, no, no. But you
Okay.
clarify so many things, make it easier. Thank you.
Yes. Don't worry about it. I'll tell you what are the indications for the cesarean section. I have decoded that. I'll tell you. Okay. Understood now. Ductus venosus is generally not preferred 32 weeks and above. However, if they've done it because she was kind of under growth problem, she was under fetal medicine specialist for a long time, they have done the ductus venosus for some joy, it's okay. Look at the short-term variation. That is what is going to tell us. Look at the maternal, well-being. That is what is going to tell us. Ultimately, your computerized CTG is going to tell us something. If computerized CTG is also normal, your ductus venosus is also normal, there are no maternal indications for us to go and deliver, it's okay. It's okay. Okay, that's fine. You still have got time, like, you can continue up till 34 weeks and then deliver her. We're not letting her go beyond that if it's an early onset FGR. If it is a late onset FGR, then it's a different story altogether. I'll come to that. Just remember this point as of now. 32 weeks to 33 plus 6 weeks. You may do the ductus venosus, you may not. It's not going to decide anything. Your short-term variation less than 3.5 is enough for us to go and deliver the baby, and that has to be a cesarean section. Okay? Another thing I will tell you now. If the baby is less than 29 weeks, okay, I'm talking about all the early onset FGR, less than 29 weeks, okay? And then from 29 to upper limit of your early onset FGR, which is 31 plus 6 weeks. At any point of time, if you're following up, you see the absent or a reversed end-diastolic flow in the umbilical artery. Okay. Then how do you monitor? You need to do twice weekly Doppler. This is one more recall that has come in the latest exam. They have given early onset FGR, mentioned it as absent end-diastolic flow, reversed end-diastolic flow in umbilical artery, Doppler. People told that we have to deliver. No. Your umbilical artery Doppler is not going to decide, even though the end-diastolic flow is absent or reverse, is not going to decide the timing of the delivery. It is the ductus venosus or your short-term variation. So how they should be monitored? So the moment you see the early onset FGR who is diagnosed in less than 32 weeks, and you have subjected them to the umbilical artery Doppler, it is showing either absent or reversed, subject them to ductus venosus and computerized CTG. Involve the fetal medicine specialist. If everything is normal, call them back twice weekly, computerized CTG and ductus venosus Doppler. Dr. Shruti, again, there is no weekly thing in here. Okay, the moment you see the Doppler changes, no weekly thing in here. It's always twice weekly follow-ups.
But that was
Clear?
only raised pulsatility index.
I'll come to it. As of now, just remember this, that once you see the Doppler abnormalities, then you, especially this absent end-diastolic flow and reversed end-diastolic flow, then you will monitor minimum twice weekly. So your question is pulsatility index of 95th centile. So you can do the weekly Doppler. That's your question, right?
Yes, yes.
Yes. So when the end-diastolic flows are there, yes, you can do the weekly Doppler. But the moment you see the absent or reversed end-diastolic flow, it is always weekly computerized CTG and ductus venosus. Your answer is justified because it was 95th centile, ductus venosus was present, but computerized CTG was also normal, then it makes sense. Yes?
That's my question. Why did we do a electronized CTG when there was no absent or reversed end diastolic flow?
Sorry, the computerized CTG. Computerized CTG is by default, dear. You cannot send her without doing a computerized CTG because that is what is telling us. It's important that both should be normal before we send her, because that is what is telling us whether the baby is in chronic hypoxia or not. Computerized CTG is the ultimate thing for us.
But
If
otherwise,
that's
according to the guideline in that patient, because of umbilical artery PI, she should be subjected to only weekly Dopplers. Right, ma'am?
yes, but you need to have the computerized CTG done. If it is normal, then weekly Dopplers.
But
You have to get the go on.
isn't the electronized CTG and the ductus venosus Doppler only to guide delivery?
Yeah, guide delivery, that's fine. But unless you do it, how do you know it's normal?
So we do it only when it's absent or reversed.
No. So you have the exact picture in here. The ductus venosus is present, umbilical artery is 95th centile, but still the baby is having chronic hypoxia. Isn't it? So why do they have to give or and all? If one is enough, then you can do it. Why do we need to do the short-term variations? Got my point? Okay, forget about all of this, even in India for that matter. Do you do the NST or not before, even if everything is normal, the scan is normal, everything is normal, they have come with reduced fetal movements, do you do the NST or not?
Yes, NST is done.
Yeah. So why do you do it? Scan is normal, blood flow is normal, end diastolic flow is present. Then why do you do the NSTs?
What is NST?
Non-stress test, which they do it in India. Yeah. Basically, it's the electronic monitoring.
Ma'am, it's mean that every patient who is kept on monitoring, we have to do the Dopplers plus this short-term variability CTG.
Yes, that's by default we do it. Antenatal CTG, which is nothing but computerized CTG. We do it before we reassure them that whether they can come for the weekly Doppler, or we have to go and deliver them. That is something by default we do it. Okay? Clear?
Ma'am, so let's say a station was where we get umbilical artery Doppler, which is showing pulsatility index more than 95th centile.
Can we answer in the form of a question? So I have got few questions and clarify it.
Yeah.
Oh, thank you. Please mute yourself and close your camera, please.
लगा है हाँ बच्चे नहीं गए शिरू उनको लाना था ना उनको
Dr.
लाना था
Ifan,
ना
please take care of your mic, please. Okay. So I will take up this. I will take up this questions. Yes, go on.
Yes, doctor. Doctor, when to do the computerized CTG, even if the umbilical artery Doppler is normal, we have to go for a computerized CTG, or once it's diagnosed as FGR, we have to go for a computerized CTG.
See, irrespective of, say, for example, even if you have diagnosed something like umbilical artery, which is raised, the pulsatility index is raised, it is more than 95th centile, she has come to you. We always do the computerized CTG, make sure the baby is okay, and then only we tell her the safety netting and the follow-up Dopplers.
Okay, doctor. And
we do not discharge her to home. I mean, we do not send her home without having the computerized CTG, which is being attached to her.
Yes, doctor. My question is whether we should go for a computerized CTG if the umbilical artery Doppler is normal.
Umbilical artery Doppler is normal means what are you trying to say? It is a GA.
Yes, exactly.
Okay, so now I'll ask you one more question. So define SGA and define the early onset FGR, late onset FGR. What is severe FGR? All of that.
Yeah, SGA is estimated fetal weight less than 10 centile with no Doppler abnormalities. And
okay. Less than 10 percentile, yes. And there's no Doppler abnormality. It's SGA. Yes. Early onset FGR?
Early onset, if the onset of the FGR, if the estimated fetal weight is less than 10 third centile, or if it's less than 10
fetal weight
centile,
or abdominal circumference?
Less than third centile,
percentile.
or umbilical artery PI is more than 95th centile, or the uterine artery PI is more than 95th centile. We define it as
so basically,
FGR.
Doppler changes should be there along with the 10th less than 10th centile to call it as early onset FGR. Anybody who is less than 32 weeks, that means up to 31 plus 6 weeks will come under early onset FGR. Okay, and late onset FGR?
If the onset is after 32 weeks, from 32 weeks onwards, but again with the same criteria. But if the estimated fetal weight, if there is a fall by more than 50th centile, then also it's a criteria for the late onset FGR. Or if the CPR is less than
severe FGR?
Sorry, doctor?
Severe FGR?
Sorry?
Severe late onset FGR.
If the estimated fetal weight is less than third centile with Doppler abnormalities, we call it
No,
as severe ST.
no Doppler abnormalities. Need not to have the
Constant
Doppler.
growth. Constant
So
growth.
enough, third centile is enough for us to quote her as FGR there. You don't have to have any Doppler abnormalities at all. Okay. So SGA less than 10th centile, but no Doppler changes is SGA. FGR, either estimated weight or abdominal circumference less than or equal to third centile or less than 10th centile plus abnormal Doppler. So less than third centile is enough for us to label it as fetal growth restricted baby. Okay. But less than 10th centile without Doppler changes is SGA. With Doppler changes, it is FGR. If that is being manifested before 32 weeks, then it is early onset, and more than or equal to 32 weeks, it's a late onset FGR. This much is clear. Now I will answer your question before I take up this thing. Whatsoever it is, if she comes to us from the midwife, she has been referred to the hospital, like be it a district or a tertiary hospital, like obstetric units. So, and even she's saying that my SGA is all okay and my baby is all okay. It's just that less than 10th centile, no Doppler changes, but we always do the computerized CTG quickly, meet the criteria, and then discharge her for the follow-up. Okay. That is something, it's like, you remember it like your normal CTG, you do it back home. So we always do that if there is any concern, making sure that everything is okay and discharge her to the follow-up. So the first question to you guys, the midwife, she's a low risk woman. She's undergoing the tummy measurements, that is symphysia fundal height measurements. So that has started from 26 to 28 weeks onwards. So every 3 weekly, she's undergoing the symphysia fundal height measurements with a midwife. And now the midwife has identified it as a slow or a static growth. Okay, slow or a static growth. So she has arranged for a biometry and a Doppler. And the fetus is now diagnosed with less than 10th centile, but normal Doppler. How will you monitor this pregnancy? This is one of the variation you can get in the exam.
Every 2 weeks, we'll do scan and Doppler.
Serial
Perfect.
monitoring since 28.
Why?
The one we discussed, ma'am, that if either of them is normal. Okay, that's for FGR.
See, that is all risk stratification from the early pregnancy. That is nothing related to this. That is high risk women. Okay. High risk women, we subject her to the uterine artery Doppler. If uterine artery is abnormal, normal, estimated fetal weight less than 10 centile, that is different here. This is the low risk category. Here, I'll show you this.
Okay,
See
yeah.
this one. Can you see this? This one. No risk factor. Anomaly scan, estimated fetal weight, everything was more than 10th centile, and we are doing the serial measurements for her. Okay. And now the symphysia fundal height is falling less than what it is supposed to be. So they have been subjected her to the growth scan and a Doppler. So now it has confirmed a case of small for gestational age, which is SGA, but no Doppler. No Doppler abnormalities. It's a clear cut case of SGA. So now how do you monitor her? This is irrespective of the gestational age I'm talking about.
Fortnightly growth and Doppler.
Perfect. Okay, it is 2 plus 2. Okay, I used to remember it as 2 plus 2, which is because we never do the fetal biometry less than 2 weeks. There's no point in doing the growth scan in less than 2 weeks, and you don't get to see any significant difference in the growth of the baby, hardly few grams. So before we used to do 3 weekly, but now it has been changed. So every 2 weekly, whatsoever it is, be it early onset FGR, late onset FGR, or a SGA, the biometry will always do 2 weekly. It's only the Doppler that changes. Okay, so it is 2 plus 2. That is 2 weekly. We do the biometry and the Doppler, which is fortnightly. Clear, everybody?
Clear.
Okay. So now the early onset FGR has been diagnosed. Say, for example, she's some 28, 29 weeks or something like that. Okay. And what surveillance would you arrange? And diastolic flow velocities, everything is present for her.
Weekly Doppler and fortnightly we'll do scan.
Perfect. Understood. It is 2 plus 1, which is 2 weekly biometry we do and weekly Doppler. Okay. 2 plus 2 for SGA and 2 plus 1 for your early onset FGR. Any doubt up till now?
No, clear.
Okay. Third, late onset FGR, she was diagnosed after 32 weeks, say for example, 33 or 34 weeks. Okay. So, end diastolic flow velocities are also present. So now what surveillance would you arrange for her?
Same.
Same.
Weekly Doppler, twice weekly scan.
Perfect. This is all you should remember. These three variations can come and it's very, very simple. So always ultrasound biometry is every 2 weeks, which is fortnightly. Only the umbilical artery Doppler which changes. So it is always 2 plus 2 here. And otherwise, in other cases, in both early or late onset, it is 2 plus 1. Clear, everyone, up till now? Clear?
Clear.
Okay. Next question. SGA fetus. Okay, we diagnosed it as SGA fetus, less than 10th centile. Somebody who was a low risk, identified on the scan, less than 10th centile with normal Dopplers. We have been doing a fortnightly growth scans and Doppler for her. All investigations are normal. Okay, she's almost term now. All the investigations are normal. I mean, you kept monitoring, everything was normal. When will you deliver her and what is the preferred mode of delivery?
39
plus
to
6.
39 plus
38 plus 6.
One of you. Yes, Basma?
We will deliver her if we find absent in diastolic flow or reverse it. Absent in diastolic flow, it will be done.
No, let's not get confused in here. Everything is normal. Okay? Everything is normal. She has come to you at around 37, 36, 37 weeks. And she's saying, Doctor, everything is normal. When are you going to deliver?
We will take her till 39
26.
weeks, 6 days.
Because
and
why
8
are you
days.
getting confused with a reversed absent end-diastolic? That then it will not be even SGA. No. SGA is only less than 10th centile with no Doppler changes.
39 week. It will be
39
normal.
weeks, 6 days.
Give me the window.
39 weeks, 6 days. By 39 weeks, 6 days, she
39
should be
to
delivered.
39 by
39
6
plus
days,
6.
it should be delivered.
Yes.
Not exceed.
39 to 39 plus 6 weeks is the window for the delivery for SGA babies who could be constitutionally small. She is less than 10th centile. The Dopplers will be normal for her. Then only we call them as SGA. We'll never let them go till 39 weeks if they had a Doppler changes. Guys, don't get it confused. Okay, all investigations are normal means Dopplers are definitely normal. She remains to be a SGA till the end of her term. So we are going to deliver her by 39 plus 6. She is not supposed to cross that. So between 39 to 39 plus 6 weeks, we are going to deliver her. And the mode of delivery, please.
Can go for normal delivery.
Yeah, induction. Okay, induction of labor for her between 39 to 39 plus 6 weeks. Perfect. Next question. So this is what I have put here, that STA, the timing of delivery is 39 to 39 plus 6 weeks. Okay. The next question. A fetus has severe late onset FGR. Okay. That means less than third centile. No Doppler changes, nothing. So again, she comes to you at around term. Okay. They have been monitoring. Everything is going fine. The baby is also less than third centile only. But there are no Doppler changes, nothing. So when will you recommend her delivery? And what is the preferred mode of delivery?
6.
37 to 37 plus 6.
Okay, any other answer?
26 plus 36 plus 6 days.
So between 37 to 37 plus 6, whoever has told the first answer is exactly right. So the moment she's term, we are going to deliver her. The last gestational age which we have reserved, that is 39 to 39 plus 6 weeks, is only for your SGA without any Doppler changes. But if she is late FGR, less than third centile, anytime between 37 to 37 plus 6 means birth has to happen by 37 plus 6 weeks. Okay, this is late onset FGR, less than third centile, no Doppler changes. Then only we are letting them cross the term gestation, which is 37 beyond. Clear, everybody?
How it will be the mode of delivery?
Mode of delivery is also by induction of labor, and we prefer the mechanical methods over the pharmacological methods.
Okay,
which
sir.
is folate. Okay.
In SGA, we
All right.
can give pharmacological methods of induction.
We can. There's no clear-cut, guideline on that. So you can definitely give because there are no Doppler changes in there, and it's not like severely growth-restricted baby. So the pharmacological methods can be considered. Okay, yeah. Early onset FGR is being monitored. Okay. Umbilical artery Doppler demonstrates. That means that the early onset FGR, once she was diagnosed, she was under the 2+1 monitoring, which is 2 weekly biometry and 1 weekly umbilical artery Doppler. And that 1 weekly umbilical artery Doppler now shows absent or reversed end diastolic flow. So what is your next step?
Delivery by cesarean section. If it is
Oh my
absent,
God, who is that? All
By
this while I have,
CDT and DV Doppler.
who is that? Basma.
basma.
All this while I told you guys that in early onset FGR, your umbilical artery will not decide the timing of delivery or anything for that matter. Who are the important parts?
Bi-weekly CTG and the ductus venosa. Sorry.
Yes. Irrespective of the gestational age you're seeing there, be it 27 weeks, 28
Once,
weeks, 29 weeks,
but
up to
once you
31
reach,
plus 6 weeks.
yes,
It is
32.
twice weekly.
If it is
Twice weekly
reversed, it
computerized.
will be from
Twice
30 to
weekly ductal
32.
venosus and
Once she
computerized
reaches,
CTG.
Let's not confuse with all of that. Now she is less than 32 weeks. Let's not cross that. Okay, she's less than 32 weeks. Say, for example, she's somewhere around 29, 30 weeks. So now how do you monitor her? Absent or reversed end diastolic flow is there. How do you monitor her? Twice weekly. Yes,
CTG or ductus venosus.
Ductus venosus and CTG.
correct. Twice weekly Dopplers. Twice weekly computerized CTG or your ductus venosus is something that you're going to do. Okay, clear up till now? Next. Early onset FGR is under twice weekly surveillance with computerized CTG and the ductus Doppler. And now she has reached 32 weeks. Okay. The latest umbilical artery Doppler demonstrated reversed. That means that she must have had some absent end diastolic flow before, and now she has reversed end diastolic flow, but she has reached the 32 weeks now. Okay. Now what will you do? When would you
Cesarean
deliver
section, but after corticosteroid.
The ductus venosus reports. Or
yes, yes, it is ductus venosus. 1 second. It is ductus venosus.
Or STV.
Yes. Okay, who is asking to start the transcript? Okay, fine. So, early onset FGR lady, somewhere around 29, 30 weeks, she was diagnosed with an absent or reversed end diastolic flow, but you have been monitoring her twice weekly, ductus venosus Dopplers and computerized CTG. Everything was going fine. Now she has come with, she has reached around 32 weeks, but now it is reversed. It was reversed before, or from absent, it has become reversed. She is 32 weeks now. When would you deliver, and what is the mode of delivery?
32 deliver now.
Right coverage with cesarean section.
Cesarean section, but we'll cover her corticosteroid first.
Yeah.
Yeah, give all of that. Will you deliver her now?
Not cat 1. It will be cat 2, cat 3, but we'll admit her.
My question, 32 weeks, will you deliver her or not? Category 3 is not like after 1 week you will deliver, right? Will you deliver her today or not?
No, cover corticosteroid within 2 days, you should deliver her. But with
32
admission.
weeks, you're supposed to deliver her. As simple as that. 32 weeks, you're supposed to deliver her. As simple as that. Because it is reversed. Okay, I will just show you one diagram. Okay, see here. Whatever the gestational age in the early onset FGR, absent or reversed end diastolic flow, you are monitoring her minimum twice weekly Doppler, which is ductus venosus Doppler and computerized CTG. Okay, everything was normal all this while. And then she reaches 32 weeks. If it is reversed end diastolic flow, deliver them by 32 weeks. You can even consider early, but remember this one so that you will not get confused. 32 weeks is where you should deliver her. Same patient, okay, you were following her up. She has crossed 32 weeks also because it was still absent end diastolic flow. The moment it is 34 weeks, you will deliver her. That means we are not letting any early onset FGR which was diagnosed before 32 weeks to cross 34 weeks for absent end diastolic flow, and we are not letting the baby to cross 32 weeks for reversed end diastolic flow when your ductus venosus, computerized CTG are normal. Clear, everyone?
Yes, but you mean that will be Cat 1 cesarean section?
No, not necessarily. It's going to be a category 3 cesarean section. Plan her, admit her as you told, admit her, give her the corticosteroids, and then give her the, depending upon the gestation age, you give the magnesium sulfate as well and plan her delivery in the form of cesarean section. Clear?
Clear.
You said
Ma'am,
that this ductus venosus and the short-term validity will be normal, then we will decide on the basis of umbilical artery in
Yeah,
early onset
exactly.
ST. Okay.
Exactly. So she has remained the same, but you cannot allow that early onset FGR who was diagnosed before 32 weeks to go until 37 weeks, right? The
Right.
baby will not
Right.
survive. So if it
Okay.
remains the same thing, like she was diagnosed to have absent, you continue to monitor her twice weekly. The moment she hits 34 weeks, deliver her. But from
Okay.
absent, it became reversed, or it was reversed all these while. Then you deliver her by 32 weeks. That's the earliest one. Okay? Clear?
Yes, ma'am. Yeah.
Okay.
Yes.
Okay, so we'll take up the next question. I think that was the question that I had. Absent and diastolic flow, we will deliver them by 32 weeks. Mode of delivery will be a cesarean section. And late onset FGR is diagnosed. Okay? Somewhere between 34 to 36 plus 6 weeks. And umbilical artery pulsatility index is more than 95th centile. That means your end diastolic velocities are present. And this is one recall question. So how would you monitor her?
By computerized CTG
Mm-hmm.
and umbilical artery pulsation is if it is raised, then we will deliver her by 36 plus 6 days.
36 to 36 plus 6 weeks. We are not letting any baby with a late onset FGR with 95th centile, okay, in the umbilical artery, we're not letting them to cross 36 plus 6. So anytime between 36 to 36 plus 6 weeks, we deliver them. But what is the monitoring until then?
Ductus venosus and ST.
no ductus venosus,
No,
just
no
No,
ductus venosus.
it's
CG.
umbilical
Twice
artery
weekly.
is weekly
Same,
and
same. 1-1.
See
Once
here.
week.
it will be
So the
weekly.
umbilical artery Doppler is more than 95th centile. Here also
1.
monitor twice weekly computerized CTG. It's always twice weekly computerized CTG. If you're dealing with an early onset FGR, you will include the ductus venosus also. Okay. Otherwise, it is only the computerized CTG, but it is always twice weekly, guys. It's not weekly. The moment you
Yes, ma'am.
see the changes there in the umbilical artery Doppler, then it completely changes from weekly to twice weekly. Okay, so twice weekly.
Yes, ma'am.
If it is an early onset FGR, you include the ductus venosus. But if it is a late onset FGR, we don't include the ductus venosus. It only the computerized CTG, which is twice weekly. If it is less than 4.5 or absent end diastolic flow, in the late onset FGR, absent reversal of end diastolic flow is enough for us to deliver the baby. Or computerized CTG is showing short-term variation of less than 4.5, enough for us to go and deliver the baby. Only absent and reversed end diastolic flow in early onset, we are not delivering immediately. We are relying upon the ductus venosus and short-term variation. But in the late onset FGR, the moment you see absent end diastolic flow, reversed end diastolic flow, or the short-term variation is less than 4.5, which is enough for us to go and deliver the baby. If it is only the pulsatility index less than 95th centile, keep calling them twice weekly for the computerized CTG. And if it remains the same even up till 36 to 36 plus 6, induce them at 36 to 36 plus 6 weeks. This is the only, three indications where you do the induction of labor. Number one, late onset FGR between 36 to 36 plus 6 weeks. Umbilical artery Doppler is more than 95th centile. That means end diastolic velocities are present. Then induction of labor using mechanical methods. Late onset FGR, which is less than third centile, no Doppler changes, then you deliver by induction of labor between 37 to 37 plus 6 weeks. SGA, without any Doppler changes, induction of labor between 39 to 39 plus 6 weeks. The moment you see absent end diastolic flow, reversed end diastolic flow, ductus venosus is abnormal in the form of A wave is absent, or it is below the baseline, or it is reversed, or your computerized CTG is abnormal in the form of short-term variation is less than whatsoever the gestational age cutoff is there. In all these cases, irrespective of early or late onset, it is the cesarean section. Clear, everyone, on this?
Yes,
Yes,
clear.
ma'am.
So I will show one more slide for you guys so that you can just take the screenshot of it and remember it. Okay, so look at this. This is all you need. The mode of delivery in early and late onset FGR. Severe FGR is abnormal computerized CTG changes like abnormal short-term variation, or you have a spontaneous, repeated, unprovoked decelerations are there. Ductus venosus changes are given. Umbilical artery is showing absent or reversed end diastolic flow. Then it is a planned cesarean section. If it is a late onset FGR, like less than third centile, okay, and SGA with normal umbilical artery Doppler, then offer induction of labor. Even late onset FGR, forget about this SGA, umbilical artery Doppler is more than 95th centile, but end diastolic flow is still present, then offer induction of labor. Clear? Clear, everybody?
Yes, ma'am.
So late onset FGR is basically third centile here. I think there is some clarity is missing in here. SGR with normal Doppler or late onset FGR. Yeah, this is the perfect one. Yeah. Can you see now? I'll just repeat this for you guys. So if you see absent end diastolic flow, reversed end diastolic flow in your umbilical artery, that means there are end diastolic flows are not there, absent. And abnormal computerized CTG or abnormal short-term variation, ductus venosus changes are there, then deliver them by planned cesarean section. Otherwise, you can induce them, be it late onset FGR like less than third centile between 37 to 37 plus 6, or SGA with a normal Doppler that is between 39 to 39 plus 6, go for induction of labor. If it is a late onset FGR who's coming somewhere between 36 to 36 plus 6, your umbilical artery Doppler is 95th centile, but end diastolic flow is present. That means there is no absent or reverse flow, offer induction of labor. So in these cases, we generally prefer the mechanical methods of induction, that is Foley's. Any question from anyone? Clear? Everyone, is it too overwhelming? No one wants to talk.
Clear.
Give me a
Clear.
break.
Ma'am,
Give me a
clear.
break. Give me a break. Please talk. Okay, so this is in a nutshell, guys. In an early onset FGR, where we have been monitoring the early onset FGR using 2+1 formula, which is 2 weekly growth scan and weekly umbilical artery Doppler. The moment we see there is an absent or reversed end diastolic flow, they will come under close monitoring. That close monitoring would include twice weekly. So from weekly, it becomes twice weekly monitoring. And we no longer more interested in the umbilical artery Doppler. We are more interested in computerized CTG and ductus venosus that is guiding us about the timing of delivery. So remember, forget about this 25 plus 6 weeks and all, it's too early, baby. Remember it as like less than 29 weeks. Okay. Or is it 29 to 31 plus 6? That is upper limit of your early onset FGR. So wherever you see any one of the following is enough for you to deliver the baby. It could be spontaneous, repeated, persistent deceleration. This is common to any of the gestation for that matter. Ductus venosus is also common to these things, which is absent A wave or it is less than baseline. Only thing which you guys have to remember, which is in the exam they're repeatedly asking, is that if it is less than 29 weeks, then it is 2.6 is the cutoff. If it is 29 to 31 plus 6 weeks, then it is 3 is the cutoff. Okay, forget about this. I don't know why it has come in here. So it is 2.6 and 3 is what you have to remember. Give them the steroids and magnesium sulfate and deliver. Between 32 to 33 plus 6 weeks, we are more interested in the computerized CTG, less than 3.5, deliver them. The exact case we had today. That is enough. It is all or. We are not interested in ductus venosus. So computerized CTG short-term variation less than 3.5, deliver them, or abnormal umbilical artery Doppler like you have seen absent or reversed end diastolic flow, that is also enough for us to go and deliver. But that particular patient had a 95th centile, the end diastolic velocities were present, but short-term variation was 3.2. So that itself was an indication for cesarean section. After 34 weeks, that is between 34 to 36 plus 6 weeks, it should be less than 4.5 to go and deliver them, or absent or reversed end diastolic flow is enough because it's a late onset FGR. 36 to 36 6 plus 6 weeks, this is one more recall. So the patient was 36 weeks, and so she came with this abnormal umbilical artery Doppler of 95th centile. So she was asking that when I can go and deliver. So you tell her that if we do the computerized CTG today, if computerized CTG is normal, then we call you back twice weekly computerized CTG. But she's already 36 weeks. So we don't have that much of window for her. So call her back in 2 to 3 days, get the computerized CTG done for her. Okay. And then you have to plan her delivery before 36 plus 6 weeks. So in this week itself, she has to deliver. Okay. That is one question that you have to practice. But any gestation for that matter, repeated provoked deceleration,
Need
there is
admission.
a medication you have to deliver. Yes?
Our case, she will need admission.
In that case, she doesn't require admission. Get the computerized CTG done for her. If it is normal, get the the preeclampsia profile done for her, blood pressure done, urine protein done, computerized CTG done. If everything is normal, you can send her home with a safety netting and call her back in 2 to 3 days of time for the computerized CTG. Okay. And then obviously we'll do the umbilical artery Doppler also to make sure that end diastolic velocities are not absent. If everything is normal, then you have to give her the date before 36 plus 6 weeks for induction.
But our case, she was complaining of reduced fetal movement and the small
Not this.
baby.
No. In this patient, she didn't have any problem that. Okay. That's one of the recall.
Okay.
So,
It is another
yeah.
record. Okay.
Yeah. Okay, so this is all we have discussed today. So remember, the umbilical artery Doppler is the primary tool for monitoring in the late onset FGR to decide the timing of birth, but not in the early onset FGR. So the primary tool will be your computerized CTG, maternal well-being, okay, and all this middle cerebral artery and cerebral placental ratio. I know you guys have been using it on a day-to-day practice in Asian regions, but here MCA and CPR, we don't do it before 37 weeks. Before 37 weeks, we are only interested in your umbilical artery Doppler and computerized CTG. It is not useful before 37 weeks. Maybe after 37 weeks, you can consider it to identify the brain sparing. And ductus venosus Doppler has no role in the late onset FGR. Okay, clear so far? Okay. So same thing, mode of birth, FGR with abnormal computerized CTG, ductus venosus abnormality, umbilical artery showing absent or reversed, go for cesarean section. Late onset FGR, which is like less than third centile, okay, and or the this one SGA with no Doppler changes, induction of labor. Just the raised umbilical artery Doppler in the late onset FGR, you can still go for induction of labor. Method of induction in SGA or FGR, mechanical methods are generally preferred, but you can still, for the SGA, you can still consider doing the pharmacological methods. Yes. So always you have to counsel her that even if you are dealing with somebody whom you can say the induction of labor is something that we can consider, as somebody told in the beginning itself that always the baby will have a less reserve, less blood supply, may not be able to cope well during the with the stress of labor, and a baby will be at a higher risk of requiring a cesarean section. That also point that has to be told to her. It's very, very important because these babies do not cope well. And another important updates in all the cases of FGR, you guys should not miss as far as your applied clinical knowledge is concerned, is that histopathological examination of the placenta should be considered in all the women diagnosed with a FGR. It will guide us in a way that basically it confirms the FGR. If it might confirm as some many blood clots were there within the uterine vessels, and It can also confirm some ischemia, inflammation, or if it is some infection, maybe the placenta may be small. So basically, it gives us so much of idea. So that is the reason that they are doing the histopathological examination of the placenta for all the babies. This you have to tell her. Okay. Second thing is that consideration has been given to screening for acquired thrombophilia for all the women diagnosed with FGR. Okay, these are the two things that you should not forget for your applied clinical knowledge points are concerned, that histopathological examination and screening for acquired thrombophilias, not now, 6 weeks after the delivery. If that comes positive, then we have to repeat it after 12 weeks. If that's also positive, then aspirin, low molecular weight heparin from the next pregnancy. And smoking cessation, they have given more importance there. And aspirin in the future pregnancy, they have given more importance. And serial growth scans, they have given more importance. I think this has remained the same from the previous guideline as well. But acquired thrombophilia, histopathological examination of placenta, you guys have to remember. Okay, so you have to cover the future pregnancy also. This condition can come back. Okay, so booking in a consultant-led care unit, no more midwifery unit, consultant-led care unit, serial growth scans, starting aspirin, following up with this acquired thermophilia testing, and following up with that histopathological examination